Dr. Prashant welcome you to this webinar on Carbetocin in action. At Hetero Doctors, we market products in different therapy areas like in gynecology, orthopedics, derma. We have very strong R&D support and we have developed many unique formulations keeping patient benefit in mind. Recently, we have introduced Carbetocin. Carbetocin, as we know, is used for prophylactic management of PPH. PPH is a condition which can lead to disaster. While there are several papers and guidelines which suggest use of Carbetocin, we would have eminent speakers today with us to give insights onto their experience with Carbetocin. Today we have got Dr. Sweta Sareen with us. Welcome, madam, to this webinar. Please share the presentation. Can you see the screen?
Yes.
Dr. Sweta Sareen is MBBS IMS BHU, gold medalist, MS obstetric gynec IMS BHU, PGDS, FMAS, and Madam experience has published several publications in reputed medical journals, presented papers in both national and international conferences, postgraduate experience of 5 years at RML Hospital in New Delhi. Madam is consultant of 1.5 years experience at Heritage Hospitals, Varanasi, fellowship in laparoscopy and infertility, 6 months. ICOG certified and diploma in ultrasonography from USA. Madam is skilled in skills in high risk obstetrics, infertility, natural access gynec surgery, gynec oncosurgery, laparoscopy, coloscopy, hysteroscopy, and ultrasound. Welcome, madam, once again. Madam, I'm sharing the slides.
Thank you, Dr. Prashant, for the introduction. So today's topic is the use of Carbetocin and in postpartum hemorrhage. So let's briefly discuss just brush up our knowledge. What is postpartum hemorrhage? So it's a loss of more than 500 ml of blood following a vaginal delivery or more than 1 liter blood loss after a cesarean section. It is very common and can occur in women who are not at risk. So we do identify certain patients who are at risk, but it can happen with anybody at any time. And it is the leading cause of maternal mortality in low-income countries and the primary cause of nearly 1/4 of all the maternal deaths globally. Next slide. So it's unfortunate, yet it's very common. So as we can see, maternal mortality is the leading cause of maternal mortality, accounting for about 35% of all maternal deaths. MMR in developing countries was 240 per 1,000 live births compared to 16 in developed countries. The global PPH incidence is 14 million women, and it's 2 to 4% after vaginal delivery and 6% after C-section. In India, 38% of maternal deaths are due to PPH. And India already has an unexpectedly high maternal death rate of 540 per 1,000 live births. So, as you can see, almost 40% of these maternal mortalities are due to PPH. Next slide. So, we all know the 4 T's, the 4 causes of PPH: tone, tissue, trauma, and thrombin. Next. So clinical findings in PPH, there's abdominal tenderness, there's circulatory collapse, increasing abdominal girth, the uterus is not well contracted, it is flabby, maternal tachycardia, and vaginal bleeding. So as we all know, there are degrees of shock. In the first stage, there is compensation, and there is a blood loss of around 0.5 liter to 1 liter. So there are no changes in the blood pressure, but then there is palpitation and dizziness, and patient has started developing tachycardia. When there is mild shock, there is a slight fall in blood pressure, 80 to 100 millimeters of mercury. Systolic pressure is slightly falling down. There's tachycardia, sweating has started, and patient has started feeling weak. When the blood loss increases to about 1.5 liters to 2 liters, there's a marked fall in systolic blood pressure. Now the patient has visible pallor, the urine output starts decreasing, and there is restlessness. And in severe PPH, when there is 2 to 3 liters of blood loss, there is a profound fall in blood pressure, there's the circulatory collapse, there's air hunger, and urine output, there is anuria. Next slide. So diagnosis of postpartum hemorrhage. Definitely, it's mostly clinical. The assessment of the patient's status, the amount of bleeding which we check, the tachycardia, hypertension, decreasing urine output. So all this, and then lab assessments. Next. So how do we approach a patient who is bleeding on the OT table or the labor table? So so the revival attempts and the management and investigations, they have to keep pace with each other. So first of all, you have to examine the patient and check the vitals, send for investigations, send for blood grouping, cross matching, coagulation profile, CBC, LFT, RFT. And at the same time, we start uterotonic agents. We check the uterus for any retained placenta or not. And we, after the uterotonics and hemostasis, and then we transfuse blood or as per the need of the patient. And so the first thing is ABC of any, like in any emergency, and then find the cause of PPH and then treat it accordingly and administer uterotonic agents. Next slide. So what is carbetocin and why it is generating so much of interest in the medical fraternity? So as we all know, up till now, oxytocin was considered to be the gold standard against which all the uterotonics were compared. And so the carbetocin is also an oxytocin receptor agonist, but these are certain differences between oxytocin and carbetocin. So oxytocin and ergot alkaloids have to be kept in a refrigerator, but carbetocin is now available, which is stable at room temperature. So there is no heat stable formulation of oxytocin at present. And oxytocin needs to be stored at 30 degrees centigrade and 75% humidity, and then it will have a shelf life of 24 months. There is no need of a cold chain per se in heat stable carbetocin. Next slide. So what is the time of administration of uterotonic agents? So there's a prophylactic use, which is for prevention of PPH, what is also known as the active management of third stage of labor. And then, of course, the therapeutic use when the PPH already started. So what are the drugs which we use? Oxytocin, carbetocin, ergometrin, along with oxytocin, and misoprostol, and of course, carboprost. Next slide. So carbetocin is the next generation drug for PPH management. It was created by making several modifications to the oxytocin structure. So what have we achieved by doing these modifications? We have prolonged the half-life and reduced the enzymatic degradation. So it's a synthetic drug. It's a long-acting analog of oxytocin. So as we all know, oxytocin either needs to be repeated or it has to be given in the form of a continuous infusion. Whereas with carbetocin, the half-life is longer, almost 60 minutes, and we can give it as a single bolus of 100 micrograms IV. And the therapeutic indication is, of course, prevention of postpartum hemorrhage due to atony. Next slide. Coming to the clinical evidence, so these are the various studies. The main is the Champion trial, which proved that carbetocin, because of course the oxytocin was the gold standard, so of course carbetocin was compared with oxytocin. And this study found there was a double-blind randomized trial, and the objective was to compare the effectiveness and safety of heat-stable carbetocin to oxytocin in the in the prevention of PPH after vaginal birth. And around 30,000 women across 10 countries, including India, were included. And the proportion of women with blood loss of at least 500 ml or the use of additional uterotonic agents was evaluated. Next slide. So now we can see the results. To conclude, after the Champion study, it was concluded that carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of additional uterotonic drugs. Next. This is the Cochrane review, which is taken from 11 studies involving 2,635 women. So the conclusion was for women who undergo a cesarean section, carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonics compared to oxytocin. Also, carbetocin is associated with less blood loss compared to symptometrin in the prevention of PPH for women who have vaginal deliveries and is associated with significantly fewer side effects. Next slide. Now, there are few recommendations. So as we can see, WHO has recommended carbetocin for PPH prophylaxis. Canada has recommended carbetocin. Ranzog, New Zealand, they have recommended active management of third stage of labor using prophylactic uterotonics, carbetocin being one of them. FIGO has recommended carbetocin for PPH management. Germany, Austria, Swiss bodies have recommended carbetocin. And FCOG France has also recommended carbetocin, as was proven by the Champion trial. Next slide. So with this, we conclude an overview of carbetocin, and now I would like to share my own experience with carbetocin in my labor room and in my OT, and why it is a superior and safer choice in PPH management. Next. So this is the first patient. This is vaginal delivery case. So third gravida with previous two normal deliveries presented with complaints of pain abdomen for 6 hours and leaking for 3 hours. There were no other findings like pallor was absent, no pedal edema, no icterus. Vitals were stable. It was a term size cephalic presentation. 2 to 3 centimeter dilated with contractions every 10 minutes, lasting for 25 to 30 seconds. Fetal heart rate was normal. So then the patient was admitted for safe delivery. A partogram was charted, labor progressed with normal CTG, and patient delivered a healthy baby girl. For the active management of third stage of labor, I used carbetocin 100 microgram IV. We did not use any other uterotonic. The estimated blood loss was, in fact, less than 300 ml, and uterus was well contracted immediately after delivery, 6 hours after delivery, and even 24 hours after delivery, without the use of any other uterotonic agent. And hemoglobin after 24 hours was well maintained, 10.6 grams. Next slide. So this next case is a second gravida at 38 weeks with previous one cesarean with a cephalopelvic disproportion. She was admitted for an elective cesarean section. The vitals were stable and it was a term size cephalic presentation. The fetal heart rate was normal. There was no scar tenderness, and patient underwent a planned cesarean section. And for active management, injection carbetocin was given, 100 microgram IV. Almost immediately, the patient's uterus contracted. There were no other uterotonics were used, and the blood loss was significantly less as compared to the use of centosanol. And post-operative hemoglobin was 10.8 gram per deciliter. Next slide. This is the use of carbetocin in a case of a high-risk pregnancy. So this was a primary gravida, 28 years old, at 36 weeks. She had twin gestation and with preeclampsia. She presented in emergency with leaking per vagina. Pulse rate was 92 beats per minute, but blood pressure was high. It was 150 by 96. And chest was clear, saturation was normal. There were bilateral pitting pedal edema. There was no pallor. And on palpation, the uterine size was greater than her dates. The first twin was transverse and second one was breech. And there was frank leaking. So patient was taken up for emergency cesarean section. And twins were delivered. First twin was a baby boy and second was a baby girl around 2.8 kg and 2.6 kg. And carbetocin 100 microgram was given for active management of third stage of labor. So estimated blood loss with all these high risks was still approximately 500 ml only. No need of any other uterotonics. There was no sudden fall in blood pressure. Vitals were well maintained. And in post-operative period, after 4 hours, the uterus was well contracted, even after 8 hours, 16 hours, and 24 hours, without the use of any other uterotonic agent. And on post-op day 1, the hemoglobin was 9.8 grams deciliter. Earlier also, her hemoglobin was 10.2 before delivery. So there was hardly any fall in hemoglobin levels. Next. So these are the three case scenarios where I have shared my own experience with Carbetocin 100 microgram IV as the first choice in active management of third stage of labor. So now we will discuss certain questions, Dr. Prashant.
Yes. Thank you so much, madam. Thank you for insights on your case studies. I was wondering why in case study 1 you used carbetocin.
Actually, sir, there were no risk factors.
Ah,
It was a simple vaginal delivery, but now we have started using carbetocin for the last 6 months, and we have
okay.
become so comfortable with its use that instead of centosonon, it has actually become the norm because there is no. I am also at peace after giving one
Yeah,
dose and the uterus remains contracted. Otherwise, with centosonon, sometimes the laboring patient, the cannula gets distorted, the infusion is not running properly, or while shifting also from the labor room to the ward, the infusion may stop. So
correct,
in
correct,
all,
correct.
just one single dose and no
We are put to rest.
misoprostol.
Yeah, yeah. And I
And
think, yes, and in PPH, you can always expect the unexpected in deliveries. You never know which
yes,
delivery go which way. And
yes,
if you're very
yes.
comfortable,
So
if there's a
as
proven track
we
record, yes.
yes.
Always.
So if we have a better molecule, why not use it?
Exactly. In fact, that's the
And
question. What is your experience? You already answered that. And
yes, so
I think heat stable is a big advantage in our country.
yes, it is a big
Yeah.
advantage. In fact, this year the temperatures in
Oh,
Varanasi,
yeah, yeah,
Uttar
yeah.
Pradesh, they were quite high, almost like 45,
Correct,
48.
correct, correct. Even
Yes,
in Mumbai, they were very high.
yes.
Even
But
today, we are
we
on. Yes.
yes, but we didn't find any drop in the
Correct,
efficacy
correct,
or
correct, correct.
yes,
And even in big cities, there is a lot of power outage. Interior का तो बात ही
yes.
नहीं है. Yes,
Uh,
yes.
and it's
Another
so
advantage could
difficult.
be single dose rather than that IV
Yes,
infusion and running here and there.
yes, yes. That
Yeah,
is a big
big
advantage.
advantage. In interiors, all these facilities may not be available every time. Any specific patient profile where doctors can anticipate a PPH?
Yes, there are certain risk factors where we can always, we have to be very, very alert that this patient may land up in PPH. So, all those risk factors, I think we all know that when there is a big size uterus, like in multiple
Multiple
pregnancies,
pregnancies.
polyhydramnios, macrosomia, diabetic mothers, then there is any episode of APH. If the patient is anemic, she's
Past
having
history also.
yes, past history. She's having preeclampsia, obesity. Sometimes the uterus does not contract very well. Any infection, chorioamnionitis, prolonged third stage of labor, prolonged syntocinon augmentation,
Mm,
sometimes prolonged inductions, several repeated prime gels, and also in all these cases,
can
we can
anticipate.
anticipate that the patient may land up in
Any
PPH.
correlation with diabetes or high blood pressure? I mean, these are common factors today, even in
Yes, these are
youngsters.
common factors.
Yes.
Yes, so definitely high, diabetes is associated with macrosomia,
Uh, yeah.
polyhydramnios. So all those cases they can have PPH and definitely preeclampsia patients.
Yes.
Abruption can happen and then per se also they are more prone for PPH.
When would you actually prefer a carbetocin over oxytocin for prevention of PPH?
So all the risk factors which we have
Yeah,
just enumerated.
enumerated.
And then there is no, I mean, there is no, I have already preferred carbetocin. So there is, that has become the protocol actually.
Correct, correct, correct. And I mean, when you have a safer and a better drug, people will
Yes,
obviously.
yes.
And what is at stake? Your life, you're saving a life.
Yes, saving a
Yes,
life. And then many people who used to say earlier that there are cost restraints, but what I feel is that when you calculate that yes, you are giving a single dose and then oxytocin, you are repeating the dose, then
correct.
IV infusion has to
IV,
be there, a cannula has to be inserted, then somebody
absolutely.
has to monitor the infusions, and then sometimes you need additional uterodonics
Absolutely.
also.
Yes,
So
yes,
you
yes.
may have to add on misoprostol, which may be given per rectally. So then, considering all this, the cost also doesn't become.
Become a significant.
Earlier, there were issues when heat stable form was not available.
Mm,
Then, obviously, but then after the heat stable carbetocin has come, life has become much easier.
correct. Can we use carbetocin in case of retained placenta?
Yes, we can use carbetocin.
Of course, I mean, This question has been coming across India, related
Yes.
percent. And this is another question, very important. In case of RH negative, mothers, of
Yes.
course, bleeding is an issue because you should get that blood
Yes.
and etc. So
Definitely we can use
same
Carbetocin.
safely.
It's perfectly safe.
Can a doctor use carbetocin for prevention if oxytocin is used for labor induction? I mean, many of the cases this would be happening.
Yes, we are using it, and
Yes,
it can be used.
it can be used.
So that
Oxytocin for
actually the
induction.
question, usually people have this question because oxytocin, as we all know, it sensitizes the oxytocin
Yes,
receptors,
yes,
and
yes, yes, yes.
that so they actually oxytocin may not be very much helpful
Correct, correct.
in such cases, but carbetocin
Carbetocin will work.
will work.
Any specific area where you prefer IV or IM? IV, of course, the action will be faster, but IM, the duration of action will be slightly longer. So, any
No,
specific area you would prefer? IV, IM,
no,
or IM?
I've been using IV
IV.
only.
But for IV, you require an anesthetist, or the doctors can straight away do
The doctor can, I mean,
it.
it shouldn't be very fast, but
Ah,
yes, it can be
yeah.
given slow. And
It's
if
not.
yes, if you don't trust like your staff nurse to be, she may not give slowly, so
Yeah,
then you can always dilute it and then ask her to push it
correct.
slowly.
But presence of anesthetist is not required for every type for IV route.
No, not in my
Okay.
experience.
If a patient is not responding adequately with carbetocin, which could happen sometimes, what would be what additional uterotonics we could use?
So if I'm given the choice, I would like to use second line
Yeah,
uterotonics like carboprost and misoprostol.
carboprost. Between carboprost and misoprostol, what is your choice, madam?
See, carboprost is easier to administer
Ah,
because misoprostol you have to deliver rectally, and
rectally.
when you are in a hurry, so carboprost has, but then carboprost has a very short duration of action,
Okay.
and then it has to be repeated. But then, if the patient is bleeding profusely, you need a faster acting.
Absolutely. Yeah.
And sometimes in some C-sections, we actually inject the carboprost directly into the myometrium also.
Okay. Yeah,
So,
many
well,
doctors. Yeah.
yes, so
And
we
for faster.
can, yes, for faster
And,
action.
and when it comes to emergency, I mean, one would use all possible things available. That's
Yes,
one thing. Yeah.
actually. So we at that point of time,
I
the
know.
the protocols and all that is
No, no.
not no
I,
longer.
I, I'm sharing my experience. I was fortunate to see only one case of PPH in JJ Hospital, and that too in late 70s. My God, the whole hospital was there. I mean, it was such an
Yes,
emergency in late 70s.
I mean, you have to call everybody, and
Yeah, yeah,
everybody
yeah, yeah.
is busy.
Yeah, and
And
everybody runs. I mean,
yes,
everyone was there at the site helping
because
the way they could.
it seems like a tap has been turned on,
Yeah, yeah, yeah.
and the
And
tap
dekhte
it's
dekhte the
pouring.
patient was, yeah, dekhte the patient was sinking, I mean,
Yes.
yes.
Within, it doesn't take even minutes, it takes seconds
Exactly,
for the patient
exactly,
to
exactly,
collapse.
exactly. What are advantages of carbetocin over oxytocin, misoprostol, carboprost, and methylergometrin, which of course hypertension is.
So, advantages of carbetocin over oxytocin we have already discussed.
Yes, yeah, yeah.
Single dose is needed, no
Yes,
need of continuous
correct,
infusions.
correct, correct,
Then heat stable
correct.
carbetocin, of course, no need of cold chain and refrigeration we have already discussed. And then prolonged labor when you have already used oxytocin infusion for augmentation, then oxytocin may not work that well. And in those cases, carbetocin definitely works. Carbetocin over misoprostol, so definitely faster onset of action. That is there with carbetocin, and misoprostol you have to insert rectally. It will take some time to get absorbed and then start acting.
Adverse
Then
effect by
definitely
its
diarrhea, shivering,
Mhm.
fever, vomiting, all these side effects with misoprostol are there. Mostly shivering and diarrhea.
Okay.
And when it comes to carboprost also has a very fast onset of action, but then the dosage needs to be repeated. It does not have a very long half-life.
Shortage.
And carboprost definitely will cause,
I mean,
shivering,
asthmatics and yes,
diarrhea. Then in asthmatic patients, we have to be very. And methyl ergometrin, I think there are so many contraindications already per se. High blood pressure,
hypertension, plus yes.
yes, you cannot give. Heart disease, you cannot give. Then RH negative mothers, you should
Oh,
avoid.
acha.
Preterm,
Oh.
preterm, you should avoid. Actually, it causes. Then if the placenta is retained, you cannot give methyl ergometrin because
Acha.
it will cause. Yes, the os will get
The
closed.
house gets closed and over.
Yes, then you cannot. So all these contraindications are there for methylargometrin. So yes, next question we can discuss.
Should carbetocin be kept as a reserve drug or it should be kept as first line? I mean, you're already elaborated, you're already using it as first line.
Yes, it can be used, it should be used as a first line drug. In
Yeah,
fact, I think WHO has recommended it
as a
as
first
a
line.
first line drug.
So
I think carboprost and misoprostol have been kept as second line.
reserve.
This is
Yeah,
the
yeah.
first line.
And if you can, I mean, finally, the goal, finally, if you're saving patients' life, you're saving patients' vitals, you're saving, I mean, it's a good thing you do.
Good thing, definitely.
How would you compare adverse effect or side effects, contraindications of carbetocin over oxytocin or other bupropion?
So carbetocin and oxytocin, the adverse effects, I don't think there are many adverse
It's
effects of
oxytocin,
carbetocin.
madam. Oxytocin, have you seen a ADH
And
type of adverse side effects?
uh, not very frequently. Not very frequently.
Although it's
But
documented,
one
but
thing
yeah,
is there that after oxytocin, especially in preeclampsia patients, after oxytocin fusion, there is sometimes fall in blood pressure.
okay.
So when the patient is under spinal anesthesia, so anesthetists also have now started preferring carbetocin over
Carbetocin.
oxytocin because the rapid fall in blood pressure is not there with carbetocin. And even in preeclampsia patients, because as soon as the placenta is out, there is a shift from the third spaces to the intravascular
Correct.
compartment. So at that point of time also, carbetocin doesn't cause a very rapid fall, a change in the vitals of the patient. So actually the anesthetist now they first come and ask कि मैडम PIH है carbetocin है कि नहीं है.
Absolutely. I
So,
mean,
so definitely. So
this
I
is this
think
is one line, your conclusion on this carbetocin in your
so.
experience. You already
Conclusion is that
elaborated, yes, you already
yes,
elaborated this.
I've been using it for the last 6 months. There haven't been any adverse side effects, and I think hardly in one or two patients we might have used an additional
It could
uterotonic.
always happen. It could always happen.
And that too, I think prophylactically, because just to have some peace of mind
Correct,
that no,
correct,
this is
correct,
a
correct,
high risk patient.
correct.
She might bleed in the night. I'm performing a
Yeah, yeah, yeah.
surgery late at night, so maybe I don't want to have that
Take a risk. Correct, correct, correct.
take a risk. So in those cases only, but then the incidence of PPH after giving carbetocin has been there have been no such
No.
cases.
Thank you so much, madam, for your insights. It was wonderful
Thank you
getting your
so much.
insights, especially, on side effects of methyl ergometry. I myself was not aware of this. Thank you
Yes,
so
not,
much.
not many people know all these
Yes, yes, yes.
side effects because RH negative also, it's a relative contraindication. I won't say
Absolutely. I'm
absolute. But then what happens is methyl ergometrin causes a very strong and sudden contraction of the uterus.
uterus.
So all the blood which is there in the uterus, it will get pumped into the mother's bloodstream.
Circulation, yeah.
Yes, so it will cause a lot of mixing of blood.
Oh, so there's a big
So
risk.
yes, so that is the
And
risk.
hypertension to high है, that.
हाइपरटेंशन तो है और
Yeah.
कभी कभी कुछ नहीं होता पेशेंट बिल्कुल ठीक चल रही होती है
Yeah.
एंटीनेटली एंड अचानक से पोस्टपार्टम शी विल स्टार्ट हैविंग कन्वर्जन समटाइम्स पोस्टपार्टम इज
Yeah,
प्रेजेंटेशंस आर
yeah,
वर्स
yeah, yeah.
सो
Okay, thank you so much, madam, for your insights.
थैंक यू डॉक्टर प्रसाद
Thanks all the doctors for taking out time from their busy schedule and attending this webinar. Thank you, Hetero team, marketing team Hetero, for conceptualizing and implementing this. Thank you, field personnel of Hetero, for organizing and coordinating. And last but not the least, thank you, IT team, for super backup support. Thank you so much. Signing off. Wish you a very good afternoon. Thank you.
थैंक यू गुड इवनिंग साइनिंग ऑफ नाउ
Thanks, Girdhar.
Thank you, doctor.